Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 15N, which is Hematology Erythrocytic Disorder. We are streaming live from PGI Chandigarh, and a very interesting and a very pertinent topic for the day, quantitative disorders of Globin chain. This is session 1. And to speak on that, we have Dr. Prashant Sharma. He is an M.B.B.S, M.D. and D.N.B from Delhi University, D.M. Hematopathology from AIIMS New Delhi, the DRC path. He is right now the additional professor in hematology department at PGI Chandigarh, with research interest which includes disorders of red cells, erythropoiesis, and laboratory instrumentation. He is also the associate editor of the Indian Journal of Hematology and Blood Transfusion since 2013. With more than 150 national and international publications, he enjoys gardening, running, and reading. Before I ask Dr. Sharma to start, let me request all of you, please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Sharma, sir, please share your screen. Let's start.
Thank you very much, Dr. Nadeem. And let me first just check if I'm audible. My slides are visible and are they in slideshow?
Yeah, your slides are perfectly visible and you're perfectly audible. Just press that hide pop-up so that goes away.
Okay,
Yeah,
thanks.
fine. Now you can start, sir. Thank you.
Thank you. Good evening, everyone. And at the very outset, let me thank the organizers for inviting me to speak on this forum. I'm Prashant Sharma, like I was just told, and my topic today is quantitative disorders of Globin chain. So we're going to be covering this in two parts, and simply because it is such a mouthful of a topic. And today we're going to be talking about some normal hemoglobin structures and function, how we name these disorders, how we classify them, and then we'll spend some amount of time on beta thalassemia in various headings. The remaining part, alpha thalassemia, HPFH, and unstable hemoglobins, which are also quantitative disorders, we will be discussing subsequently on another day. So, hemoglobin disorders go back a long way, and virtually as long back as humanity itself, really. About 10,000 years ago, this was a terracotta skull, which is now in France, but was initially recovered from Turkey. And this, you can see the typical porotic hyperostosis that's going on in the skull. And yeah, so there has been some debate amongst archaeologists and archaeohematologists, if there's something like that, about what it really represents. But the consensus is that this is probably a hyper proliferative anemia, most consistent with a thalassemia major. And then, of course, we're aware of the fact noted by Haldane that a lot of these disorders of red cells show a striking similarity in distribution with areas that are endemic for malaria. So that's another reason why they've been around for so long, because the heterozygous state affords some protection against the more severe forms of malaria. And this gentleman over here is Thomas Cooley. He was an American pediatrician who also worked a lot in France, and he was the one who first gave us detailed descriptions of what was till then called Mediterranean anemia, and he suggested the name of erythroblastic anemia for obvious reasons. So again, these are disorders that have been having their own share of limelight. These disorders, unfortunately, disproportionately affect the lower and the middle income countries of the world. And this is a picture from Bangladesh, where these are children with E-beta thalassemia, one of the most common causes of non-transfusion dependent thalassemia worldwide, on the World Thalassemia Day. So when we're talking about these, it's important to be clear about the nomenclature that we're using. So when we say thalassemias, remember that this is a reduced production of a structurally normal globin chain. So the reduction could be in alpha globin, beta globin, or both the delta and beta globins. But at the end of the day, these are quantitative disorders. And then we have something called the hemoglobinopathies. Hemoglobinopathies are disorders resulting from production of an abnormal globin, and this results in the production of a variant hemoglobin. So examples are hemoglobin S, C, D, J-Merit, etc. So unlike thalassemias, these are qualitative disorders, which means that you can try to detect the abnormal the variant hemoglobin by hemoglobin HPLC or electrophoresis. And then you have disorders which straddle the two worlds. These are the thalassemic hemoglobinopathies, and examples of these are hemoglobin E, Lepore, and Constant Spring. And there's an Indian variant called hemoglobin Coadora. All of these disorders in the last point are characterized by reduced production as well as the production of a variant hemoglobin. So they are hybrids. Now, these disorders together are extremely common if one takes into account the heterozygous state. So, according to one respectable estimate, about 5% of the world's population has at least one thalassemia variant allele. So, when you have 5% of the population walking around as heterozygotes, they're going to be marrying each other, and you will begin to get compound heterozygotes as well as homozygotes. And if within the early years of the 21st century, we expect just short of 1 million individuals with clinically significant disease to be born. And believe it or not, the majority of these are likely to be in the hugely populous South Asia as well as southern China regions of the world. So these are disorders which are autosomal recessive, which means that the parents are going to be carriers in virtually all the situations. The parents are themselves going to be asymptomatic, so they will not know that they have a serious hemoglobinopathy, the potential to transmit a serious hemoglobinopathy until they have an affected child. There are exceptions to the autosomal recessive rule, and these are unstable hemoglobins and dominant beta thalassemias that we will deal with somewhere along the way, either today or next time. The intriguing part about why these disorders have reached such high frequencies. If something is deleterious, then over time evolution tends to weed that particular trait out. So the reason why these disorders not just persist but thrive at what are really polymorphic frequencies is the fact that they confer genetic resistance to falciparum malaria. And how do they exert this genetic resistance? This is because of so this is because of several reasons which I'll just come to, but this is not just limited to the thalassemias. This is also seen in the hemoglobinopathies, a wide range of them, as well as membrane defects like Southeast Asian ovalocytosis and some forms of erythrocytosis. Variant blood groups and variant glycophorins can lead to resistance to malaria, and G6PD deficiency is also well known to be associated with it. And G6PD deficiency is a disorder that's also very common in our country as well as the other places where thalassemia is common. So how does it work? So what are the mechanisms by which erythrocytic resistance is provided to falciparum malaria by THAL? We can't go into detail, but there's been a lot of research on this, and it is partly because of decreased merozoite entry, resistance to intracellular growth of the parasite. There's a reduced lysis of the erythrocyte at the end of parasite maturation, so the merozoites don't get released. And there's an increased phagocytosis of thalassemic parasite-infected RBCs. There is decreased adherence of infected RBCs to other cells, which we know is one of the major pathogenetic features of falciparum malaria. And there is an increased immune response to malarial infection, possibly because of exposure of neoantigens on the red cell surface. And there's a lot of epidemiological as well as in vitro evidence for each of these mechanisms. But coming back to the thalassemias proper, before we study a disease, we need to classify it. So we can classify thalassemias into subtypes based on the precise chain that is underproduced. So alpha thalassemia, beta thalassemia, delta beta thalassemia, and gamma delta beta thalassemias are the most clinically significant ones in this group. Their frequencies, of course, are different. On the other hand, gamma and epsilon varieties. So these are also non-alpha chains. These varieties are not clinically significant beyond early infancy, simply because by that time they should have been replaced by beta chains. So if somebody has an inherited underproduction of the gamma chain, they are going to be anemic as neonates, but they will slowly get better. The other way to classify thalassemias is according to the extent of the defect in the individual genes. So this is well known. We can have beta naught or beta plus, or there should be another plus here, sorry, a beta plus plus kind of a situation where you have either no production of any globin, you have some production of a normal globin, and in a beta plus plus state, you have a reasonably large amount of beta globin, although it is still less than what should have been normal. The other way these mutations can be classified is actually on the basis of what has happened genetically. So one can have missense mutations, insertions, deletions, indels, and so on. In beta thalassemia, the defects are usually one of these four types. Rarely, thalassemias can be acquired, and this is true for both beta and alpha, but most of the acquired thalassemias are alpha thalassemias, and these are almost always associated with MDS and rarely a myeloproliferative neoplasm. The classification of beta thalassemia that we use most often, however, is the one which is a clinical based. And in this, the most severe form of the disease is called transfusion dependent beta thalassemia, or TDT. This was previously known as beta thalassemia major, and most of these patients are going to be homozygous for a severe mutation. So a combination of beta naught, or a combination of beta naught beta plus. These people are going to require lifelong blood transfusions to sustain life, and if we don't transfuse them, then they are going to be dying within the first 5 years or so of their life. Then we have a group of patients. These are less common than the transfusion dependent ones, and these are called non-transfusion dependent thalassemias. Previously, they were called thalassemia intermedia. Now, these patients are symptomatic, but the key difference from TDT is that they do not require repeated transfusions to sustain life. So they may require intermittent transfusions, but they should not be dependent on that to simply survive. And although blood requirements are lower, these patients are not asymptomatic, remember. They may still develop complications, especially iron overload and extramedullary hematopoiesis. And then at the extreme other end of the disorder, we have people who are heterozygous. And sometimes you will see them being called carriers or beta thalassemia traits. So these are all synonymous terms. They are asymptomatic for the most part, and that's because these are autosomal recessive disorders. So both copies of the gene need to be, both the alleles need to be affected. However, they are still of genetic importance because they serve as reservoirs of the disease, and if they marry another carrier, they can transmit the disease. So for those of you who are interested, now today we're going to be sticking just to the postgraduate level, but there's been a lot of interesting research on beta thalassemia carriers, and their microcytic hypochromic RBCs have some special properties which, unlike the transfusion-dependent thalassemias, make them more resistant to thrombosis and some other advantages that these traits have. So you could read up about it, that it's not just malaria, but and the trade-off for a slightly lower hemoglobin and abnormal indices is there for thal traits. Now, the primary event that happens in the symptomatic thalassemias is a globin chain imbalance. So what happens in both beta and alpha thalassemia is that the impaired production of one type of globin chain is going to cause an imbalance in what is otherwise a very finely controlled alpha to beta chain ratio. This is normally kept at 1 plus minus 0.05, but obviously if there's an underproduction, the opposite chain is going to increase in number, relative number. So while the alpha to beta 2 tetramer, which means the adult hemoglobin, is a highly soluble molecule, but single chains or their dimers and tetramers tend to precipitate adjacent to the RBC membrane. And this phenomenon is worse for alpha tetramers than it is for beta tetramers. So what it means is that for an equivalent genetic defect, the beta thalassemia with an excess of alpha chains is going to be clinically worse. Beta globin production usually begins by about the last 3 to 4 weeks of pregnancy, and it abruptly increases after birth. So at birth, adult hemoglobin and fetal hemoglobin are roughly competing for dominance. But by 6 months of age, the adult hemoglobin has taken over, and which is why we observe that patients with beta thalassemia major tend to present at around 6 months to 1 year of age because their hemoglobin F has declined. So this again is of practical importance, therapeutic importance, because many of the efforts which are aimed at correcting thalassemia at a gene level are actually aimed at re-inducing HbF, because if it comes back, it should be able to take over the function of the missing adult hemoglobin, the beta chain. So what are the effects on the erythrocyte? The major effect of the unpaired chains on the erythrocytes are the oxidative effects of oxidative injury. And that's because the unpaired chains which have an attached heme are going to be susceptible to oxidation. So these oxidized alpha chains in beta thalassemia are partly proteolized to form iron-containing hemichrome pigments, and which are basically peptide fragments which are highly reactive. What they do, the hemichromes act as Fenton reagents and they generate ROS, and then we all know that the ROS is going to oxidize all the structures in the membrane that they come in contact with, whether it's lipid or proteins or even DNA. So this is a diagram where we can see the various effects of the membrane-bound globin chains which have precipitated. And what happens is ultimately there's a generation of various kinds of free radicals. In addition, there is generation of free iron, and that again is extremely toxic in the cytosol. A part of it is converted to methemoglobin that has its own problems, and we ultimately end up having not just the oxidative part of damage, but the ensuing non-oxidative damage as well. So what happens to the red cell membrane? When we have a partially oxidized alpha globin chain which is binding to the membrane skeleton, the first thing it will do is disrupt phospholipid bilayer asymmetry. And those of you who are familiar with the pathogenesis of apoptosis would realize that really this is an invitation for the cell to undergo intramedullary cell death. So we're talking about the red cell precursors if their phospholipids are getting exposed. It's been observed that thalassemic erythroblasts as well as red cells have abnormal cytoskeletal composition. There is an increase in band 3 and with clustering of band 3, so which is normally an aging related change. There is a decrease in spectrin and chirin and band 4.1, again an aging related change. There is an increase in rigidity in alpha thalassemia, and there is an increase in friability and instability of the red cell membrane in beta thalassemia. There is also abnormal hydration of the red cell, by which we mean that the ratio of water to hemoglobin and other solutes in the cell is altered. The beta thal red blood cells are dehydrated, whereas the alpha thalassemia red blood cells are relatively hyperhydrated, and this leads, but either way, it leads to decreased deformability and increased removal by the spleen. So why do these patients have anemia? Well, the answer lies both in the bone marrow as well as the peripheral blood. In the bone marrow, we have ineffective erythropoiesis, which means that the red cell precursors are undergoing apoptosis as well as phagocytosis. And this is because of exposure of phosphatidylserine as well as abnormal antigens, as well as decreased sialic acid, and the formation of neoantigen antibodies against the erythroid precursors. On the other hand, the red cells in circulation in beta thalassemia have a survival time only 1/3 that of normal RBCs. And there is also increased cytokine production. These cells normally red cells act as cytokine sinks, which means that they mop up the immune response by removing cytokines. But in the case of thalassemia, the cytokines like increased TNF actually end up activating monocytes and macrophages, making them more phagocytic. So with that basic background of pathogenesis, let's move to the next step of pathogenesis. And the underlying observation behind this next part of the talk is the fact that even thalassemia patients with the same genotype don't always behave clinically, that is, they don't have the same phenotype. Or another way of putting it is that thalassemia is a monogenic disorder, but clinically it often behaves as a polygenic defect. And that is because, in addition to the beta globin gene defect, other genetic modifiers also come into play. So let's start with what are primary modifiers. Primary modifiers are the original beta thal mutation that a patient has inherited. So these can range from null or beta naught mutations, which I already told you are characterized by complete absence of beta globin production, to those that cause only a minimal deficit, that is the beta plus plus mutation. So these are when you have the beta thalassemia mutations are typically a single base substitution or a minor insertion or deletion of a few bases. This normally happens within the gene or within its splicing sites or in its immediate flanking sequences, the 5' or 3' UTRs. Remember that these mutations may affect any level of genetic regulation, that is the beta globin gene transcription, its post-translational processing of its pre-mRNA, or the translation of its mRNA into protein. And this is the major reason why we have such a lot of heterogeneity in the final effect. So the 5 commonest beta thalassemia mutations in India are the IVS15G2C, the IVS11G2D. These are both mutations that affect splice sites. Then we have 2 frame shifts, a codon 89 and a codon 4142. Sometimes you will see them written as frame shift 89 and frame shift 4142. They are the same. This is a single nucleotide insertion and this is a 4 nucleotide deletion. We have one medium-sized, let's say, deletion happening in beta thalassemia as well. The 619 base pair deletion is common amongst the western parts, people from the western parts of India, and it's in many studies it's the second most common mutation that is found. Less common mutations include codon 15, codon 16, a mutation called cap +1, and another one called -88, and some of these we will discuss when we talk about specific features of different mutations. Moving on to secondary modifiers. Now these are loci that affect the alpha to beta globin chain imbalance or the degree of HbF response. So in a way the degree of HbF response is also influencing the alpha beta globin chain imbalance because it's providing an alternative to the beta chain. But starting first with the alpha globin genotype, it's been noticed that those patients with beta thalassemia major or transfusion dependent thalassemia who co-inherit alpha gene deletions, especially if they get more than one, have an ameliorating effect on their phenotype, which means that they get better. And that is expected because we know that alpha chains are one of the major villains in beta thalassemia. On the other hand, if somebody has a co-inherited alpha gene triplication or quadruplication, this tends to exacerbate beta thalassemia of all types. So let's see specific examples. Patients who have homozygous beta naught thalassemia, that is, they are expected to be transfusion dependent, but they co-inherit HbH disease. So again, a lot of it will be clearer once we talk the next time. HbH disease, patients have only one functioning alpha gene. These patients end up becoming thal intermedias or non-transfusion dependent thalassemia phenotypically because they don't have that many alpha globin chains to now precipitate. On the other hand, if somebody is a beta thalassemia trait, but he has inherited a defect where there is an increased alpha globin product. So again, it will be clear next time how sometimes the same mutations that can give, the same deletions that can give rise to alpha thalassemia can give rise to triplicated or quadruplicated alpha globin genes in another allele. So if somebody inherits this sort of a genotype and has a beta thalassemia trait, they will become symptomatic. So they will usually end up behaving like a non-transfusion dependent thalassemia. The other secondary modifier is a variant in fetal hemoglobin production. And that's because increased fetal hemoglobin can reduce the ratio of alpha to non-alpha globins. How does it do that? Because simply there are genetic polymorphisms that can increase gamma globin production even beyond infancy. And once that happens, they can combine with some of the alpha chains and reduce the dyserythropoiesis and ineffective erythropoiesis. erythropoiesis going on in the bone marrow. One of the most prominent polymorphisms in this regard is the XMN1 G gamma polymorphism. This is present in the G gamma gene, and it explains about 1/3 of the genetic variance within the level of HbF. And more recently, other loci have also been discovered. So the HBS1L and MIB, these are two genes, and in their intergenic region are many polymorphic sites which can influence HbF levels. And in addition, in BCL11A also, there are multiple polymorphisms, and depending on what a patient has inherited, they may be lucky enough for their HbF levels to go up. And then there are tertiary modifiers. So what are these? These are loci that are not involved in globin synthesis or imbalance, but they modify the progression and complications of the disease. So how do they work? For instance, the iron overloading in beta thalassemia, and we'll see that this is one of the major consequences of the lifelong transfusions that these patients require. This is predisposed to in Western populations by mutations in the HFE gene, or sometimes people can call them polymorphisms because they are present in a very large proportion of people. And then again, bone disease in thalassemia. These patients have osteoporosis and osteopenia. This is influenced by polymorphisms in transforming growth factor beta 1, the vitamin D receptor, and the collagen genes. In addition, the risk of heart failure, this is one of the leading causes of death in these patients, is influenced by the by the genotype of apolipoprotein E that the patient has inherited. There are specific HLA alleles that affect the tendency to hepatitis and liver cirrhosis that they have been worked on. And then again, the many polymorphisms that control a person's prothrombotic influences also influence the tendency to thrombosis in these patients. So this is a summary diagram of the genetic modifiers of phenotype in beta thalassemia. The primary modifier of phenotype is the beta globin gene defect that the patient has inherited. That is the cause of his thalassemia, major or intermediate. And then we have alpha globin copy number as well as fetal hemoglobin levels, which are the secondary modifiers. And they are less in importance to the primary modifier, but still of major importance. And then we have a lot of tertiary modifiers which influence specific complications. So we have the VDR, estrogen receptor, collagen receptor for bone disease, HFE for iron, ApoE for heart failure, and UGT1A1, which is the Gilbert as well as Crigler-Najjar gene for jaundice. So when all of this is going on, the patient will finally come to the clinical attention with a particular clinical manifestation, a set of manifestations. So in transfusion-dependent thalassemia or thalassemia major, these include very severe anemia, hepatosplenomegaly, jaundice, pigment gallstones, a plethora of skeletal changes. The typical thalassemic facies characterized by maxillary prominence, malar prominence, prognathism, and so on, osteopenia, osteoporosis, bony masses, they can have extramedullary masses, pain, growth failure, changes in body habitus. They will have iron overload by and by, inevitably. Endocrine and metabolic complications are rife because of iron deposition in endocrine organs, starting from the pituitary and manifesting as hypothyroidism, hypogonadism, and insulin resistance, heart failure, thrombosis, pulmonary function abnormalities, pulmonary hypertension, and leg ulcers. When we look at patients with non-transfusion dependent thalassemia, and this is these percentages are from a famous article because NTDTs are more difficult to study. They are more pleiotropic in their manifestations. So these patients tend to have more incidence of osteoporosis, extramedullary hematopoiesis, hypogonadism, cholelithiasis, thrombosis, pulmonary hypertension, abnormal liver function, leg ulcers, again endocrinopathies, a lower risk of heart failure that was higher up in thal major, and diabetes mellitus. Okay, so that was the pathogenesis and the clinical part, and linked with that, we are going to now proceed on to the genetics of beta thalassemia. So I've been speaking for about half an hour now, and maybe I can just check with Dr. Nadeem if there are any questions in the chat box, which I can't see. the previous part was coming through, because I really am not getting any feedback. Oops, maybe I need to call up Dr. Nadeem.
Hello?
Yeah, hi. Oh,
Yeah,
glad to hear your voice. Could you hear
welcome
me?
back to you. Yeah, I could hear you, yeah. Absolutely
Okay.
fine, right. So this is session one.
Well, I'm not finished yet, but I just thought I'd take a break since it's halfway.
Yeah.
And did anybody have any questions so far?
There are no questions, but somebody had just commented regarding the sound part, but now it is all settled. So I don't think so that there's an issue. Your sound part is absolutely fine now.
Okay, I'm glad to hear
So,
that.
yeah,
So I guess if there are no questions, we'll save time and just march on relentless.
that
And
would be nice. Yeah,
yeah, so you could just let me know if I'm back in slideshow.
yeah, you are. Please start.
Thank you very much. So moving on to the genetics of beta thalassemia, about this, let's first start with the hemoglobin, the normal hemoglobin. As we know that the adult hemoglobin is a tetramer of alpha 2 beta 2 chains, and that's why we have to call it a heterotetramer. It has four heme groups that lie in clefts on its surface, and these are equidistant from each other, and there's a plane of symmetry across this globin, which has a single plane of symmetry. The alpha globin chains are composed of 141 amino acids, and the beta globin chains are composed of 146 amino acids. At this point, I'd like to mention that these chains have an evolutionary history. They have arisen from a single common ancient gene, which underwent gene conversion and gene duplication events, and which is why all globin genes and consequently the globin chains share a lot of structural homology with each other. So, to this audience, I'm sure it's well known that if adult hemoglobin was alpha 2 beta 2, then HbF is alpha 2 gamma 2, and HbA2 is alpha 2 delta 2. So, the gamma chains are encoded by two gamma globin genes, and the delta chain by a delta globin gene. There are some pathological variants, but both of these concern alpha thalassemia, so I think I'll skip these in today's talk. So the chromosomal locations of the beta globin as well as the alpha globin gene clusters are important. When you have a gene that's arisen in over time by duplication, you are going to have a gene family. So the beta globin gene cluster is located on chromosome 11 on its short arm, and the alpha globin gene cluster, there are two alpha globins per chromosome 16 of the human being. So these are located two on each arm of chromosome 16. And this I've already told you that evolutionarily these genes have arisen by duplication of one another, and therefore they look a lot alike on sequences. So this is a closer look at the alpha and beta globin gene clusters. So what we have going on here, and just focus on the image on the top at the moment. This is chromosome 11, 5 prime to 3 prime. This is the major producer, the beta globin, which is present most 3 prime. Then subsequently, these are the two genes which are in play during in utero life, the G gamma and the A gamma. They are virtually copies of each other except for a nucleotide here and there. And then we have the delta globin gene, which gives rise in combination with the alpha globin to HbA2, and this is a gene which is hypomorphic, which means it doesn't produce a lot of mRNA or protein, and that's because of certain changes that have happened. And maybe at this point I'll just mention that there's been interest in even upregulating the delta globin gene by studying exactly what is the epigenetic mechanism that or the sequence that is turning it off. That who knows that if the minor hemoglobin A2 goes up, then again for thal majors we may have a cure at hand. So that was beta globin. Now alpha globin cluster, we have two alpha globin genes, the alpha 2 and alpha 1. And then at this point, maybe should mention that both in the alpha globin cluster, we have an LCR and there's another one. So in the beta, we have the LCR, which stands for the locus control region. And this is a regulatory region which has the binding sites of a lot of transcription factors which are going to be produced elsewhere in the genome. And they're going to come and bind here as well as at various sites in the subsequent cluster. And there's sometimes and what it does is it loops around and directly activates the transcription of the genes. So this activation of each of these genes proceeds sequentially through the embryonic life. So first we have the epsilon, then the GNA gamma, and then around 35 weeks, the beta globin starts to function. So moving on to the gene itself, and although this is the structure of the HBB or the beta globin gene, this is, remember, the general layout of all the globin genes. So we have in all of these genes two introns or coding sequences separated by 3 exons. Introns or non-coding sequences separated by 3 exons or coding sequences. And you have promoters and enhancers, and this is the beta globin gene which is amplified over here. Just a gentle reminder at this point of time that we're currently looking at the DNA sequence of this gene, and the central dogma of molecular biology states that DNA gives rise to mRNA via transcription, and mRNA is translated into a protein. So that's how it works for the majority of the genome. So looking more closely at the beta globin gene, there are some sequences that we need to be aware of to understand how mutations can make them go awry. So here you can see that flanking the introns are sequences which are identical. So these are called, and obviously we know that where the intron and the exon are meeting, it's going to be a splice site, because, just a second. Yeah, because ultimately the introns are going to have to be spliced out and the exons joined together to give us the mRNA. So a big group of mutations can occur at the splice site, which are identified by the invariant dinucleotides, and around them, just outside, are the consensus sequences. So we have a spliceosomal complex which is going to be identifying these sites, and if there's some problem in their identification, then the mRNA is not going to be normal. And then I would like you to focus on these motifs over here. These are upstream promoter elements, and these 3 are very well known: the Tata box, the CCAAT, and the CACCC homology boxes. So these localize the site of transcription initiation in the gene. And then this particular slim red line is something called the cap site. So what is a cap site? It is an N7 methyl guanosine cap. So this happens when this becomes the first nucleotide of the pre-mRNA, and once this methylation has happened, it protects it from exonuclease cleavage, and it also then subsequently facilitates the pre-mRNA splicing, polyadenylation, again something that's happening at the tail of the mRNA, and protects it from degradation and nuclear export. So it serves to reason that if there's a mutation happening at the cap site, even though all the promoter sequences, even though the sequences of the gene itself are going to be normal, but we will have underproduction of the beta globin. So we already know that the molecular basis of beta thalassemia predominantly is point mutations and some deletions like the 619 base pair, and mutations can occur any of the sites, any of the steps that we just discussed. And the mutations, depending on how much they affect how much underproduction they cause, can be of these 3 types. So let us look more closely at the mechanisms. So the common mechanism of beta thalassemia, is mutations that affect RNA processing. These are single base changes that involve the splice junctions, and what they do is they abolish normal RNA splicing sites. And remember, so we have a handful of splicing sites, and if they are not going to be working okay, then almost certainly we are going to have a beta naught kind of a mutation. So single base substitution within the consensus sequence that we just saw of the intervening sequence 1 donor site, which means intron 1. This is a common event, the substitution of G in position 5 with another nucleotide. This results in a severe beta plus thalassemia, and in fact, this is the commonest Indian mutation, the IVS 15. Mutations can also sometimes create new splice site. So what happens is that the original splice site is undisturbed, but instead a new splice site got created by the mutation at another place, which can be either in the intron or an exon. And I'll just show you an example at position 110. So what happens is that if these new splice sites are more attractive to the spliceosomal complex than the original one, then they will be used preferentially. And the third way, of course, is that splice sites can get abolished. So you can get abnormally long mRNA. And another mechanism is activation of cryptic or alternative donor sites within exon 1. So again, you're going to have abnormal splicing. And yes, so HBE, although this is not a part of the job entrusted to me, remember this was a thalassemic hemoglobinopathy, and that's because there is an alternative donor site which is created. So you'll have a variant hemoglobin, but also being produced in lesser amounts. So this is an example of a minus 110 mutation. We can see this is the IVS1, and the normal splicing will happen at these junctions. On the other hand, if there is the creation of a new splice site, then instead of this, the spliceosome is going to recognize this as the new site from which to start the second exon. So what will happen is that we will have an extra 19 base pairs included, 19 nucleotides included in the mRNA. So theoretically, this may not have led to too much of a problem because we could have gone on till the end of it. But what happens is that once this intronic sequence is also being taken into account, then there is a stop codon lying over here, which normally gets ignored because this area would anyway get spliced out. So you have an abnormally small mRNA, which is obviously of no use. Then we have mutations that can affect transcription. So these, as one can imagine, are slightly milder mutations because the mRNA at least is probably going to get formed. These can be mutations in the promoter region, which are the 3 boxes that we saw earlier. They can be leading to the decreased binding of RNA polymerase, as well as decreased rate of RNA transcription to just about 20-30% of normal. And of these, the prominent mutations are those at position minus 88 and minus 87. So when we say minus 88 or minus 87, we mean that it is upstream of the coding sequence. So this is relative to the mRNA cap site, and they are close to the promoter region. And one of these mutations, the minus 88C2T, is the commonest one found in Jet6 in Punjab. It wasn't there in the top 5 list that I had shown you earlier. Okay. Then there can be mutations that cause abnormal translation of messenger RNA. These are usually nonsense mutations that can change an amino acid codon into a chain termination codon. And obviously, these are the 3 nonsense or stop codons. So that is not going to be a nice thing to happen because your protein is going to stop abruptly. And this prevents further translation of the mRNA and results in beta naught thalassemia. And this can sometimes happen, abnormal translation can happen because of indels, insertions or deletions of a nucleotide number other than 3. So it's going to lead to a frame shift. 2 of these are common in India, and I already told you about frame shift 89 and frame shift 41-42. And then there are a special group which are not inherited autosomal recessively, unlike the other thalassemias, the overwhelming majority of thalassemias, but are dominantly inherited. So what happens here is that the mutation happens really far down the gene in exon 3, and this leads to the synthesis of truncated or elongated but highly unstable beta globin gene products, and these gene products are going to be precipitating within the RBCs and adding to the precipitated alpha chains, which of course still have nobody to combine with, and they will then be symptomatic even in the heterozygous state, and that's why they are dominantly inherited, and you can actually see the inclusion bodies. So with that, we're now heading into the last part of the class on the laboratory diagnosis of beta thalassemia. The genetic aspects that I mentioned are just a taste of the things that can go wrong. The beta globin has been a really instructive genes in terms of showing us what all range of changes can happen when a gene decides to undergo mutation or is forced to undergo mutation, probably more likely. And there are many other things like poly A tail things. Sometimes rare things can be involve translocations, transacting factors, which I haven't gone into today because they're rarer than the things that we discussed. Okay, so coming to laboratory diagnosis. So this is a diagnostic algorithm for the workup of thalassemia and hemoglobinopathies. It has to start with the clinical background, and then we go on to the complete blood count. The complete blood count can be normal in persons who are carriers of alpha thalassemia, and we'll discuss alpha thalassemia next time. But most of the times, if you have a microcytic hypochromic kind of a blood picture, and you're reasonably sure from the RDW and some indices that this is not iron deficiency, you need to go in for further testing. So there is something about thalassemic red cell indices which can tip you off about the possibility of a thalassemia, and I'll show it to you in a case study in a minute. The next test to be done typically is a hemoglobin HPLC. It mentions electrophoresis here because this slide was originally meant to cover both thalassemia and hemoglobinopathies. But in the context of thalassemia, you need to go in for a technique that quantitates hemoglobin F and quantitates hemoglobin A2. And based on what you get from those results, if you have an hemoglobin A2 which is elevated and an F which is not markedly elevated, you're likely to have a beta thalassemia trait. If you have an A2 which is normal range and an F which is may or may not be elevated, you have an alpha thalassemia trait. If you have an A2 which is elevated but also an F which is between 5 to 50%, then of course you need to correlate it clinically. You're looking at a beta thal intermedia or an NTDT. And HBH I'll skip and the variants I'll skip. And occasionally, if you're not clear after this, most cases will get clarified, but if you're still not clear, we'll need to go in for DNA analysis. So the HPLC and sometimes people can use capillary electrophoresis are the two commonly used techniques for quantitation of hemoglobin fractions. This is what a normal HPLC looks like. You have the numerical data on the top and you can see the A, F and A2 percentages here. The A gets labeled as A0 because it can separate out P2 and P3, which are also the subfractions of adult hemoglobin. And then you have the chromatogram, which also you need to take a look at. So within the chromatogram, you have windows which are designated by the software, and you have various fractions coming in various windows, which I'm sure there'll be a class from someone somewhere. And you have a differential diagnosis for a region which is not covered in the windows. So when you interpret HPLCs, you start with the clinical background, look at the age, look at the last transfusion. This is critical because the percentages of hemoglobin fractions are going to change if a patient has been transfused. We look at the CBC data and we look at the HPLC, and finally, and then we, if required, go in for ancillary studies. So there are some general rules for beta thalassemia. The normal range of hemoglobin A2 is between 2 to 3.3%. For diagnosis of beta thalassemia trait, we require a raised HbA2 but up to 9%. So in HbA2 between 4% to 9% is elevated, consistent with beta thalassemia trait, as long as the indices are also supporting it. For a case of transfusion dependent or even independent beta thalassemia, we need to have a raised hemoglobin F, which is usually more than 45%, which is always more than 45% and usually more than 70 to 80%. The HbA level, of course, is going to vary depending on how much space F is occupying, and A2 levels are often increased but can also be normal or reduced. So let's just quickly roll through some cases. They're really straightforward, really. This was a 20-year-old pregnant lady, and her hemoglobin was a little low, but then she's pregnant. Her RBC count is disproportionately high for her hemoglobin. And so for a woman, the normal range for RBC count would be 3 to 5 million per microliter. She has microcytosis, normal range 80 to 100, hypochromia, and RDW, which is slightly increased. So with this, we would say, summarize it as mildly reduced hemoglobin, microcytic hypochromic red cells, relative erythrocytosis, and a mildly increased RDW. So what's going on? Well, we can try calculating the Menzer quotient, which is a simple one, MCV divided by RBC. This is 11.2. This is suggesting the thalassemia trait. So, but the RDW is also elevated. So one has to keep in mind that this is most likely with coexisting iron deficiency. She's pregnant after all. And this is the HPLC. As we can see, her adult hemoglobin is okay, her F is okay, she's pregnant, and her A2 is 5.2%, so which is elevated. Remember, 4 to 9% is beta thalassemia trait. The HPLC has no other abnormality other than the elevated A2. So what we have here are just an elevation of A2, and the diagnosis is beta thalassemia trait. So at this stage, we'll advise HPLC of her husband as well as that of her brothers and sisters, because they are likely to have a 50% chance of having thal trait as well. So what happens if her husband's HPLC also shows beta thal trait? Well, then they have become a couple at risk, which means that they have a 25% chance of having a beta thal major or a transfusion dependent beta thalassemia child. So if the period of gestation is less than 20 or 24 weeks, depending on how many doctors' opinion you need, you can offer her prenatal diagnosis if the couple wants it, and you can offer that. We will let you know if your baby is affected. So moving on to case 2. Now this is a 1-year-old girl. She's a Sindhi girl from Gujarat, and she has severe anemia and hepatosplenomegaly. Her hemoglobin is extremely low, 2.9 grams per deciliter. She's not been transfused so far, but she obviously desperately needs transfusions. And her RBC count is proportionately reduced. She has severe microcytosis and hypochromia. And look at her RDW, it's massively elevated. And this is her blood picture. Other than the microcytic hypochromic cells, the target cells, we can also see a very large number of erythroblasts. So this was the HPLC which came, and a 1-year-old should have a fetal hemoglobin not more than 5%. Her fetal hemoglobin was 96%, and adult hemoglobin at 1% was virtually absent. So what we're dealing with over here is most likely a transfusion dependent thalassemia or a beta thalassemia major. At this point, I have to remind you that you must, in this case, also advise parental HPLCs. And that's because our case seems to be an open and shut case of thal major, but there are other differential diagnoses for conditions with increased HbF. So this can happen in normal neonates, especially premature babies. In persons with homozygous beta thalassemia, of course, that we know, that's what our child had, but also in people with homozygous delta beta thalassemia. We'll talk about it next time. Homozygous HPFH, again, something that will come up later, and any of the combinations of these three. So people who are double heterozygous for, say, beta thalassemia and delta beta thalassemia and HPFH, and so on. Quickly moving on to case 3, this was a 12-year-old boy with intermittent jaundice and anemia. So he's been unwell for a while, he gets jaundice on and off, and when they examined him, they found splenomegaly. But he's never received a transfusion, so he's made it till 12 years. Right now his hemoglobin's low, 6.3, but he's he appears to not be in CHF. People with chronic anemia tend to adjust their physical activity and compensate. And there is microcytosis and hypochromia, and the RDW is elevated. So the next thing you do is order an HPLC, and this is what it showed. The hemoglobin F was 31%, the A2 was normal range, and the adult hemoglobin was proportionately low. And the HPLC shows the increased F. So together with these findings, the diagnosis is a clear-cut case of non-transfusion dependent beta thalassemia. And this typically happens when the person inherits 2 beta plus mutations. So the causes of F in the range 15 to 45% will include non-transfusion dependent thalassemia, African type HPFH trait, and a thal major who's been transfused. You should never forget that. Maybe the history hasn't been provided. We should, in such a case, it is imperative to do family studies, parental studies to confirm TI, because they can also be acquired causes of increased HbF. In our patient, the clinical background is suggesting thalassemia intermedia. Okay, so this is a question that I think I'll come to very quickly. So, what are the causes of non-transfusion dependent thalassemia phenotype? It can be because of homozygous or compound heterozygous cases, or mild, which is beta plus or beta plus plus mutations, or a severe mutation, which is co-inherited with either alpha thalassemia or a plus plus XMN1 polymorphism or HPFH, or persons who are compound heterozygous for beta thalassemia and HBE, or delta beta thalassemia with beta thalassemia, or HPFH with beta thalassemia. They will also have less transfusion requirement than beta thalassemia major. So we really, so again at this point I'll take a pause and check with my host to see if there are any questions so far.
Yes, there is.
Oh, okay, tell me about it.
Dr. Nilesh Kapadia is a very famous pathologist in Ahmedabad. He has put up a question. He says, why alpha thal are less? Is it related to some genetic loci or locus it associated?
Hi, Dr. Kapadia. Thanks. That's a great question because, and that's a very astute observation. So, before I launch into the answer, I must tell you that the frequency of alpha thalassemia trait in our country is actually higher or greater than the frequency of beta thal trait. Okay, but paradoxically enough, the symptomatic forms of alpha thalassemia are seen much less commonly than beta thalassemia major and intermediate, right? And that's probably the reason why you're asking the question. So what happens is, and I'll explain this in detail in the class on 18th, is that in India we have a form of alpha thalassemia which is alpha plus thalassemia, which means that on a particular chromosome 16 we have one allele, which one gene between alpha 2 and alpha 1 which is intact, and the other one which is deleted. Alternatively, you can have a mutation like you can have a deletion like the minus 3.7 kb deletion, which still gives rise to a hybrid fusion product which has alpha gene producing activity. So what does it mean? It means that a lot of Indians with alpha thalassemia trait who are going to be marrying other South Asian. Sorry, can you
No,
hear me?
please go ahead. Please go ahead. Yeah.
So, unlike two people who with beta thal trait who are marrying, they will reproducibly have 25% of the kids if they have enough children. You'll see that frequency as thal major. On the other hand, if two people with alpha plus trait get married, they are not going to have a child with HBH disease or hemoglobin parts hydrops, which will come to attention. So I don't know if that makes sense because it's usually more helpful with a diagram, but it's a clue if you want to explore it yourself, or maybe you could just log in and I'll address it on the 18th.
There is another question by Dr. Oshan Shrestha. He
Hi,
says, good
Oshan.
evening, sir. Can beta thalassemia also be acquired?
Hi, Oshan. He's a PGI alumnus and one with whom I've worked closely. Oh, yes, it can. So, the acquired forms of beta thalassemia are even rarer than the super rare acquired alpha thalassemia. For instance, I think after many years, we recently got one more report. But yes, it can. And the mechanisms are again that in the face of genomic instability because of a hematological malignancy, really strange things can happen with the genome. Yeah.
There are no more questions. We can go ahead.
Right. So I'm just thinking. Some part of today's talk, I think I'll move into the next one because alpha thalassemias per se are less. So just bear with me for maybe another 5 or 10 minutes.
No
May
issues.
I go
Yeah.
ahead?
Yeah, please go ahead. Yeah. Perfect. We
Okay.
are enjoying it.
Thank you so much. Okay, so we'll now launch into genetic diagnosis. So far what we've looked at is the pathogenesis and the type of mutations and the defects that can go wrong. But but we must, as pathologists, be familiar with what you do if you're faced with a patient whose HPLC is suggesting thalassemia. So for that, it's really helpful that in India, the mutations which are common are really common. By which I mean that if you take the first 5 mutations in this list and you test for them, you would have covered more than 90% of the thalassemic alleles that you're going to encounter in any part of the country. And the a clear winner in terms of frequency across groups other than immigrants is the IVS15G2C, which we saw was a splice site mutation, followed closely by, not very closely, followed remotely by 619 base pair deletion, and then the another splice site and two frame shifts, the codon 89 and 4142. So with this background, let's see how laboratories can go about detecting these. But before we detect these, first let's see if it's required. So genetic diagnosis, remember, is not always indicated in thalassemia. It is indicated mostly in a patient who's transfusion dependent. So you have a child who by the time he or she is referred to you is 1.5 years of age. They are on their 6th transfusion and they are not going to ever go off transfusions. Both their parents are beta thalassemia trait. So you want to confirm whether they are thal major, and for that you need to do a DNA analysis. Another big group in bigger centers has now become prenatal diagnosis. So if a couple has already had a thal major baby, or they've found out during preconceptional testing that prenatal antenatal testing that they are both thal traits, they might want to know if the baby is going to be a thal major. Well, then you need to do a molecular test because HPLC won't help in an in utero stage. And then another group sometimes is patients who have clinically unclear diagnosis and where other DDs have not been excluded. So let me just explain this. Occasionally you'll have a child who's at 8 months of age or 10 months of age with a high F and hepatosplenomegaly and anemia, and you will have both his parents being beta thal trait. But remember that two beta thal traits at the end of the day have a 25% chance of having a child who's in every pregnancy of having a child who's thal major. So that doesn't clinch their being thal trait doesn't clinch the diagnosis for the kiddo, right? So what you need to in such a situation, suppose the clinician says, I haven't really ruled out JMML because HbF can go up there and they can have hepatosplenomegaly and failure to thrive. So then you'll have to say, fine, then I'll have to do the beta thal mutations. So with this background, once we decide that we need to do the test, what are the techniques that we need to put in practice? So for beta thalassemia and any alpha or beta variant which occurs due to point mutations, one of the most high yield systems is something called the amplification refractory mutation system PCR or AIIMS PCR. You can also, if you can find a restriction enzyme that cleaves at the relevant site or very close to it, design a PCR restriction fragment length polymorphism. There is a cost-effective strategy which can be multiplexed very easily called reverse dot plot hybridization. And then as laboratories and patients both get more technically advanced and richer respectively, we can straight away go in for Sanger sequencing, which is also good for small-sized problems. Alpha thalassemia, just a sneak peek, is often caused by deletions. So you need to have another set of weapons in your armamentarium, gap PCR or multiplex ligation dependent probe amplification. So looking first quickly at reverse dot plot hybridization, this is done by many centers, though not PGI because of some robustness issues. But the principle here is that we design a nylon membrane onto which probes for different mutations, DNA, oligonucleotide probes, are immobilized. And once we have a membrane which looks like this thing over here, we take, and whenever a patient comes, you can make these membranes in bulk and keep them. So whenever a patient comes, you take that person's genomic DNA, amplify it using biotin labeled primers so that you'll be able to detect them later through fluorescence, and hybridize them to the membrane strip here. And in each of these, sorry, not fluorescence, but the streptavidin biotin reaction. So in each of these strips, you will have to set up two sets of combinations. So you'll have IVS15, this is the probe for the wild type sequence, and this had the probe for the mutant sequence. Frame shift 89, wild type, mutant, and so on and so forth. So what we will then do is that once we have the strip, we're going to hybridize our patient's genomic DNA to this, and then look for then do a lot of washing and see whether the hybridization occurred or not. So in persons who don't have a particular mutation, you're going to get just the spot in the wild type region, right, and nothing in the mutant. But for the mutations which the patient is possessing, you'll get a spot in the mutant region as well. or just there. So because this person hybridized with the wild type as well as the mutant probes, we know that this person is heterozygous for frameshift 8-9, and similar situation for IVS11, so heterozygous for this. So we are probably looking at a beta naught thal major child. Yeah, and the other mutations were absent. So this is actually a real life example, and in each of these strips, the panel, the row on the top are the wild type sequences probes, and the one on the bottom is the mutant probes. So this first sample is normal for all of these mutations that were tested. This one, I think, yeah. So because we designed this strip ourselves, we know that here we had put the biotinylated probe for the sickle hemoglobin in this particular row. We mass produced these strips in advance, okay, before the patient came. So this patient amplified with both wild type and mutant sickle, so S trait. This one is IVS15 heterozygous. Here what's happening is that IVS15 has amplified, but the wild type primer for IVS15 has not amplified. So this person is homozygous. You could ask me, why are these also missing? Is this a technical error? No, these are mutations which are very close to the IVS15. So we already know from our past experience with this reverse dot dot that whenever we get the IVS15, these spots are not going to come. So in a way, it's like a quality control. And this is because we know that here we put in the codon 30. This patient is heterozygous for codon 30 mutation. Coming on now to amplification refractory mutation system, which is the system that we use at PGI. This is a form of an allele-specific PCR, but not just any allele-specific PCR, it's a very special one. And why? Because in this we have two sets of primers, a mutant and a wild-type primer. And these primers are identical to each other, except that they will differ only at a 3' terminal base. And we know this makes it obvious that we can only use this in a single base pair change substitution that's happening. So basically the mutant primer has a mismatch with the wild type sequence, but a match with the mutant sequence at the 3' end. And to make it specific, sometimes you can introduce other changes as well. So how does it work? When we put in, so we have two primers, so we normally set up two different tubes. When we put in the normal primer, if the patient has the normal allele, it is going to bind perfectly, and the 3' end binding is extremely essential for a proper PCR reaction. So you're going to get a product. The amplification will happen. On the other hand, if the patient has the mutation and we've put in the other primer, the wild type primer, this is not going to bind. So with the wild type primer, you will, so actually in this particular example, this DNA is again the wild type DNA, and when we put in the mutant primer, which instead of an A has a C at this 3' end, there is going to be no complementarity, and then the DNA dependent RNA polymerase is not going to amplify the subsequent part of the segment. So this is what the gel actually looks like. We've got two different PCR reactions. This is a control band. So again, just going back. So this is a very beautifully or cleverly designed PCR, because a control primer is put in within the sequences, and there's another control primer, the opposite primer to this, that is going to amplify within this area as well. So because we are ultimately going to be looking for the presence or absence of this particular band. So the control band has to come every time. Each lane is a different PCR reaction. So for codon 8-9, when we put in the mutant primer, we got the mutant product, but with the wild type primer, we got no product. So we can say that this particular patient is homozygous for the codon 8-9 mutation. And this was probably another primer, because you can see that the length is different. We compare them against the ladder, the base pair ladder here. So this is a gel showing the 5 common mutations by AIIMS PCR. They have to be done separately, but you can try multiplexing a few of them. So this is the IVS15. These are all mutant primers, not in pairs. Frameshift 8-9, a different size product. CAP+1, IVS11, This is the 5X marker, frameshift 4142, IVS15, and the 619 BPD deletion. So you could ask me that 619 BPD is not a single base pair deletion, right? It's a 619 base pair deletion. It's not a substitution or a missense mutation. So how do you use AIIMS PCR for this? Well, what happens is, and again, I should say the sheer innovativeness of the person who designed this becomes obvious. The control band, if the 619 base pair deletion has happened, becomes much shorter. It actually starts working like a gap PCR. So because we got the usual control band as well as the 619 BPD band, regardless of whichever primers we put in, remember, because the control primers were the same for all of these tubes, right? So because we got these, had any of these samples also had the 619 BPD, we would have got this additional band over here. So we can say that whoever's DNA was in this lane is heterozygous for the 619 BPD. On one part, the deletion is not there, but on the other allele, the deletion has happened. I hope that's clear. And then we're really drawing towards the end now. This is an example of an RFLP, the restriction fragment length polymorphism. It's a universal technique, so suffice to say we amplify a region, then we use a restriction enzyme to either cut or not cut the PCR product depending on what is the motif that the restriction enzyme is recognizing, and then we simply run the fragments after digestion on a gel to see the sizes obtained. And this is an example of PCR RFLP of I told you about the XMN1 G gamma polymorphism, which influences HbF levels. So the XMN1 is actually an enzyme, and in persons who have the wild type, which is the minus genotype, the enzyme is not going to cut the amplified band when we expose this band to the XMN1 restriction enzyme. On the other hand, if the person has a plus genotype, then he has the polymorphism on both alleles, so we'll get two smaller bands. And if a person has plus on one allele and minus on the other, he'll get a band of the wild type as well as the bands of the polymorphic. So we know that this person is heterozygous. He has both these two kinds of patterns. This is another PCR RFLP for HBD Punjab. In this one, there is a loss of restriction. There's a loss of restriction site. So the normal has two smaller bands, and the homozygous person is going to have a single band which didn't get cleaved by the EcoR1. More and more labs are now using Sanger sequencing. This is a chain termination kind of reaction where, in addition to the deoxynucleotides, we add differently labeled dideoxynucleotides as well. And depending on where this is happening randomly, the incorporation of that dideoxynucleotide happens, the chain is going to get terminated. And while we're running a PCR reaction, the sequencing PCR, so to speak. And then all we have to do is electrophorese these products. They are all there's a very high resolution electrophoresis. We're going to see the depending, so 1, 2, 3, 4, and we'll get the sequence. So this is what a Sanger sequence looks like. Let me show you an example here. This person is heterozygous. There is a G and a C which got detected in this area. This person has a frame shift mutation because the sequence is clean till here, but subsequently it's got garbled. So so what we do in sequencing PCR is we put in only the forward primer or only the reverse primer. So we're just seeing either the plus strand of both the alleles or the minus strand of both the alleles. If they match, then we get a clean sequence with just the mismatch here. But in case a frame shift has happened in either of the alleles, then the sequence will not overlap and a garbling is going to happen. So I think this is going to be my last slide for today. When you look at beta thal major versus intermedia at a genetic level, this is a thesis by Amarjot Kaur, Dr. Amarjot, who's our senior resident now. So this is the data that she got. So look at the layout of mutations. This is a 3-year study, and when we look at thal major or transfusion-dependent thalassemia, we get the top 5 that we talked about earlier. IVS15, 609 BPD, frameshift 89, IVS11, and frameshift 4142. These are the commonest mutations. When we look at thal intermedia or non-transfusion dependent thalassemia, the situation changes. The top mutation becomes -88C2T. A new entrant comes into the top 5, which is CAP plus 1. This was at number 8 in the thal major list. And obviously everybody else has to move down. The IVS 11 now becomes, out of the 5 commonest, it becomes the second most common in the NTDT. And that's because the IVS 11 is often associated with an XMN1 plus plus kind of a genotype. These are closely inherited. IVS15 is still there, but it's now relegated to number 3, and then we've got the others. And another point that can be made from this slide is that mutations can remain unidentified, especially in NTDT, in a proportion of patients. So there are a few pitfalls of molecular techniques. Deletions are not detected by both endpoint PCRs as well as Sanger sequencing, so be careful. Large deletions may fall, and if they are present, along with something, a point mutation on a contralateral allele, will end up looking as if they are homozygous for the opposite lesion if you have done Sanger sequencing or endpoint PCRs. You can design the best primers, but if there is a naturally occurring polymorphism in your patient at the point where the primer is binding or the restriction enzyme is binding, then the PCR is going to give you an opposite result to what you expect, because these are all based on whether your primer or RE found their site or didn't find it. And the globin genes overlap extensively because of similar evolutionary origins. So one has to be careful, especially regarding alpha globin gene sequencing data. So I'll just walk you through my conclusions. Quantitative disorders of the globin chains are relatively common. They're usually clinically severe in the homozygous state. They are potentially preventable by timely carrier detection and offering prenatal diagnosis to the affected couples at risk. Diagnosis of beta thalassemia trait can be done using hemogram data and HbA2 quantitation. And detection of increased hemoglobin F along with typical blood counts and smear findings with judicious use of parental studies and molecular genetics can help diagnose transfusion dependent and non-transfusion dependent thalassemias. Thank you.
Thank you, sir. Excellent presentation.
Thank you.
There is a question, or rather a continuation of the question by Dr. Nilesh Kapadia. He says alpha beta ratio is maintained normally, but how in compound heterozygous thalassemia is it maintained? Which compound, the next part of it is, which compound heterozygous are beneficial or which ones are more severe?
Could you just repeat the first part? The
I
alpha beta
will.
ratio? Yeah.
He says alpha beta ratio is maintained normally, but how in compound heterozygous thal is it maintained?
Not really. I mean, I don't know why you'd say that.
Yeah, I mean, I'm not getting the wordings of it.
Let me, okay, please go on. Yeah.
The next part of it, which compound heterozygous thal are beneficial and which ones are more severe? Please explain why.
Okay, so let me try and answer this as I understand it. But in case I'm wrong, then Dr. Kapadia, please just feel free to call me up or write to me or put it in the chat box. So the commonest compound heterozygous state in India, which is clinically very relevant, is HBE beta thalassemia. Right, so one allele has HBE, which is codon 26, and the other one has any of these beta naught, let's say, mutations. So those patients are going to be symptomatic because the alpha beta globin ratio is not maintained, because the amount of the E chain can bind alpha, but it's still half. The other allele, the thalassemic allele, is producing nothing. So there is an excess of alpha chains, and which is why those patients will be symptomatic with Hal intermedia. You're in Calcutta, so I'm sure you know better than me that the heterogeneity. Sorry, yeah.
Yeah, please go ahead. Please go ahead. Sorry.
That these E beta can have a whole host of heterogeneities simply because they can inherit other things as well, and that's probably what you're asking in the second part. So let me put it this way: so if somebody's got two beta naught mutations, but at the same time was lucky enough to co-inherit XMN1 plus plus genotype and let's say an HBH disease, 3 alpha chain deletions, then that lucky person is going to be thal intermedia, because the many things get taken care of. On the other hand, if somebody has two mild mutations but also inherits, not even that, somebody has one mutation, a beta thalassemia trait, but co-inherits alpha triplications or quadruplications, those patients can sometimes get into trouble when in times of hematological stress. During pregnancy, the hemoglobins can really drop, or the hemoglobin F can go up, because again the balance went awry. So I would say the beneficial combinations are the ones which either increase hemoglobin F or reduce the alpha workload, alpha allele load.
The next part of his question is how to work up in such cases to diagnose it. What will be the
Yeah.
diagnostic modality?
That's again a great question, and the great questions often don't have very straightforward answers. So I would suggest, what we do is we work our way through the modifiers. So we first ascertain the beta globin defects, and then we go in for XMN1 plus XMN1 status, the alpha deletions and the alpha triplications. So there's a multiplex PCR for alpha, which I'll talk about next time, and you can screen for 8 of them in one go, the deletions, and you can again multiplex the triplications and look for 3.7 and 4.2 deletion, kilobase pair deletions in one PCR. So till here it's fairly reasonably quick and cost effective, because these, the endpoint PCRs are not so expensive. But if they're still unexplained, and then you have to start thinking, and luckily those patients are very few, but you have to start thinking about transacting factors. Somebody has thal intermedia, but the beta allele is looking okay. Then you need to think about XMN1 and KLF, and sorry, not XMN1, but KLF, BCL11A, those sort of things. So they really do behave like polygenic disorders.
Right, Dr. Nilesh Shapadia has a comment. He says it's a very nice presentation.
Thank you, sir.
Indeed, a very nice presentation, very nicely explained and very extensively done up. We'll be eagerly waiting for the part 2 of it.
Thank you, sir. It's very gratifying that you liked it.
Right.
I must acknowledge my. I'm sorry.
Yeah,
May I
go ahead,
go?
please. Your
So I
volume is
must
coming down.
acknowledge. Okay, yeah, that's because. So I must acknowledge the constant help and support of my boss and colleague and friend, Professor Reena Das, whom I'm sure many of the listeners know, and as a very friendly and approachable hematology faculty at PGI. A lot of this data and the work and the lab standardization has been Madam's efforts over the decades, really, and she was the real expert. Yeah, so I have to say that, and we have a wonderful team of technicians who help us with this, both the HPLC and the molecular.
Great. Right. Thank you, Dr. Prashant Sharma, for such a wonderful presentation. We'll be looking forward to the next session. Right. Till then, take care. Good night. Bye-bye.